dear colleagues, dear friends, good afternoon. It's a great pleasure for me to visit this charming city and historic Craiova. I would like to thank the presidents. It's okay? Yes. I would like to thank the presidents of the conference, especially Professor Marius Curie and Kostas Saparidis, and the organizing committee for this kind of invitation for me to represent my university and show you our scientific and research job. I'm Professor Konstantinos Vlachos, head of the surgical department of the University of Ioannina, and from northwest of Greece, and this round table will focus on some new threads in surgical oncology. The first speaker is Assistant Professor Georgios Llanos. He's the worldwide respected surgeon who's among the 3 most cited surgeons in gastric cancer surgery. And he will tell us about the novel approaches in gastric cancer treatments. Unfortunately, his speech will be delivered to you by video because due to some last-minute unexpected difficulties.
Good evening. Thank you so much for your kind invitation. It is a great honor for me. However, for personal reasons, I was not able to be there. I will give a talk about gastric cancer treatment and novel approaches. I declare no conflict of interest. As we all know, gastric cancer continues to be a leading cause of cancer-related mortality worldwide, and the highest mortality rates are observed in Eastern Asia. However, are all centers able to offer an adequate carcinological treatment for gastric carcinoma? The radical gastrectomy is the cornerstone of the treatment. And the multimodal treatment of gastric cancer contains radiation therapy, immunotherapy, chemotherapy, antibiotic prophylaxis, supportive care, nutritional support, endoscopic treatment, adequate lymph node dissection, and first of all, surgical treatment. And if we want to talk about early gastric cancer, we know that it is a cancer limited to the mucosa and or submucosa, regardless of the lymph node status. And the incidence of node involvement is about 3% for mucosal early gastric cancer and 20% of the submucosal early gastric cancer. A new concept that we are studying is sentinel lymph node. And this issue, we have to talk about how to identify sentinel lymph nodes. We have data on sentinel lymph node detection. What are the main obstacles to sentinel lymph node detection? And if this method is effective and accurate, and what about oncological safety? Is sentinel node application surgery oncologically safe? Recent evidence support that stomach pain procedures improve quality of life, but we have to be sure about wrong data in the literature. And if we want to talk about the identification of sentinel lymph nodes, the first problem regarding this concept was the mapping using an appropriate and efficient tracer with advantages and disadvantages. And in this issue, we can use indocyanine green, pattern blue, and IV. Do we have any data about the detection of sentinel lymph node? Some years ago, we have published an interesting study about sentinel node navigation in gastric cancer and where do we stand. And we have highlighted the that sentinel node navigation for gastric cancer is a topic that remains highly controversial, and there is a need for clinical trials on this topic. We have to highlight the great importance of the complex lymphatic drainage of gastric cancer. And this complex lymphatic drainage leads to the phenomenon called skip metastasis. About the sensitivity of Q method versus radioisotope, we have that the sensitivity, the specificity, and the accuracy are about the same. And this is highlighted for important studies of published in Annals of Surgical Oncology. As I have mentioned before, the main obstacle is the phenomenon called skip metastasis. And which are the most common sites of skip metastasis in gastric cancer are lymph node station 7, 8, and 9. And we have to highlight that the lymph node 7 is the node of the left gastric artery. In this site, we have many skip metastases. And for this reason, the lymph node mapping is very difficult. Is effective in that way, this lymph node detection. Some studies report accuracy of almost 100% and is oncologically safe. In this issue, we have the detection rate is highlighted to be almost 100%, and the overall survival of some patients about 98%. But I insist in this issue of skip metastasis. It's very difficult, in my opinion, to use sentinel lymph node navigation in gastric cancer setting. We have introduced from our department another important issue. We are in the area of personalized, minimally invasive surgical oncology. And in this area, with this terminology that we have introduced in the literature, in Translational Gastroenterology and Hepatology journal, we have highlighted that in the area of personalized, minimally invasive surgical oncology, sentinel node navigation may have an important place, but after randomized trials with many patients. Now, I would like to talk about advanced gastric cancer. Advanced gastric cancer, we mean gastric cancer stage 1B to 3 stage, and for these patients, as you all know, the important thing is the surgical treatment. The surgical treatment also for patients, old patients, who, with the Department of Surgery of Policlinico University Hospital of Milan University Hospital, we have published an important multi-center study in updates in surgery dealing with laparoscopic distal gastrectomy in all old patients. This study was the first Western experience, and we have proved that all those patients may have important survival after laparoscopic distal gastrectomy. And we have to be very honest with these patients in order to offer to them the appropriate surgical treatment. The important prognostic factors for these patients related to long-term survival for patients with advanced gastric cancer were the stage of the tumor, perineural and perivascular invasion, and metastatic lymph nodes. Dealing with novel approaches in gastric cancer treatment, I would like to highlight another important study from our department, an invited perspective article published some years ago at Personalized Medicine Journal about the concept of complete mesogastric excision. Complete mesogastric excision for gastric cancer. Is it the future of gastric cancer surgery? And I'm very proud that this paper is from our Department of Surgery, from the University Hospital of Ioannina, in collaboration with the third Department of Surgery of the Lycon General Hospital of Athens. We have highlighted that this novel important issue may be very, very useful for gastric cancer patients. Undoubtedly, gastric cancer remains one of the most common and deadly cancers worldwide. Complete mesogastric excision emerges as a novel and feasible technique that can be utilized for the resection of gastric cancer with a curative intent. We have highlighted that the incorporation of complete mesogastric excision is being contemplated for both conventional, open, and minimally invasive techniques. This new concept is still in its beginning. We have to be careful in its beginning, but the first results are very encouraging. Several other studies have proved that complete mesogastric excision is associated with less intraoperative bleeding, with a greater number of lymph node harvested, and less time to first post-operative plasma, with important rates of disease-free survival and overall survival. We have to highlight that complete mesogastric excision is the equivalent of the whole plane, is the equivalent of mesorectal excision of patients with orthocolic cancer, with complete is the equivalent with CME in right cancer colon. Can we be sure that complete mesogastric excision is the future of gastric cancer surgery? Not yet. More studies will come and will bring light in this issue. Another issue about gastric cancer is the oligometastatic gastric cancer. Oligometastatic gastric cancer, several years ago, all of these patients with stage 4 gastric cancer were directed to palliative chemotherapy and palliative treatments. But all these patients are the same. The N1 patients, stage 4 N1, are all the same for a palliative treatment. Yoshida from Japan have categorized these patients in 4 categories and have important papers from Japan prove that multimodal treatment in oligometastatic gastric cancer can lead to several good results in order of survival. And if we want to talk about oligometastatic gastric cancer, we have to say that the oligometastatic disease, in some patients, we can have as main goal the L0 resection in highly selected patients. In highly selected patients, we can have after chemotherapy, we can prove a surgical resection. Which patients do we choose? We have to choose patients. We have to highly select patients in order to have some hope for a better survival rate. Long-term survival after a liver metastasectomy in gastric cancer, an important systematic treatment meta-analysis of the prognostic factors in literature prove that if we have solitary or 3 lesions, if the max diameter was 5 centimeters, if the metastases are metaphorous and we have negative margins, in these patients, the L0 resection can be feasible. What is the ideal scenario for these patients? ideal scenario is when we have a solitary metachronous liver metastasis. And we have to be careful about consensus on chemotherapy treatments and randomized clinical trials. I want to, in this, on this issue, to highlight that we are awaiting the results of two large randomized clinical trials, two RCTs, the FLOT5 study and we be in the French surgical study that are comparing the continuation of chemotherapy versus surgical removal of the primary tumor and the metastatic site in oligometastatic gastric cancer. The results are expected to revolutionize the global surgical community. I would like also to highlight the surgical trial from the Professor Christophe Mariette that have recently passed away from the hospital, from the Department of Digestive and Oncological Surgery, Lille, France. And what about the patients with positive peritoneal cytology? This paper is from our department with the collaboration of Professor Stefano Rausei from the Department of Surgery of Varese Hospital in North Italy, and is published in a very important journal, the Giornale di Chirurgia, that is the journal of the Italian Surgical Association. And at this moment is the most cited article from the Italian surgeons about the management of positive peritoneal cytology gastric cancer patients. Is there any hope for these patients? The answer is yes. When we select these patients carefully for surgical operation after the treatment with chemotherapy treatment. Well, treatment options for patients with cytology positive gastric cancer without other non-curative factors, we can have upfront gastrectomy with adjuvant therapy, we can have palliative systemic therapy, we can have intraperitoneal therapies, and we can have this new concept that contains upfront systemic therapy and then gastrectomy. This is the future from positive peritoneal cytology patients without other non-curative factors. All surgeons we are not alone. We have the oncologists, we have the neoadjuvant chemotherapy, that offers for gastric cancer, offers combination regimen FLOT trial, important published in Lancet Oncology from Alba Tran. FLOT trial and FLOT regimen have revolutionized the gastric cancer treatment. Patients after FLOT therapy can receive surgical treatment and then can have FLOT adjuvant therapy. We can combine neoadjuvant treatment, surgical treatment, and then adjuvant treatment. And this is proved from important studies in the literature. What about immunotherapy? Immunotherapy is a new concept for gastric cancer treatment nowadays. It's the concept that will revolutionize the treatment not only for gastric cancer, but all the field of surgical oncology. Immunotherapy in liver cancer, immunotherapy in gastric cancer, immunotherapy in colon cancer. Important issue that has to be highlighted in the next years, in the future. Novel approaches in immunotherapy with ramucirumab, with nivolumab in advanced or metastatic gastric cancer. We have little data, but the first results are very encouraging. And we have also to highlight the important role of ADC ADCs, antibody drug conjugates, monoclonal antibody that leads to better survival rates of these patients. In conclusion, I want to highlight the importance of personalized medicine. I would like also to say that from more conservative surgical options to radical lymph node excisions, we are called to choose the best way to help our patients. We have to combine theoretical knowledge and surgical excellence. We have to be trained about this in specialized centers. The only fact is that we have much more to expect incorporating in our treatment plan surgical treatment, immunotherapy, targeted therapies, and novel approaches with antibody drug conjugates, nanotechnology. All this can lead us to improve the quality of life and the survival rates of gastric cancer patients. And in this point, I would like to show you some photos from my recent fellow at the Cancer Institute Hospital at Tokyo, Japan, with Chief Takeshi Sano. These photos are from their department with the lymph node dissection, Cancer Institute Hospital, Cancer Screening Center, Cancer Institute, Cancer Chemotherapy Center, Cancer Precision Medicine Center. I would like to thank you all. I would like to thank also Professor Takeshi Sano for his hospitality and good evening. Thank you so much.
I think we should move to the next speaker. Next speaker is Dr. George Nanakis. He is a resident in my surgical department, and he will try to introduce us total mesopancreas excision, obviously inspired by total mesorectal excision for rectal cancer. Mesopancreas is increasingly recognized nowadays as a surgical and oncological space key for achieving radical resection. George, please.
Good evening. My name is George Spanakis. I'm resident at University Hospital Ioanna. I'm very glad for the invitation to the Conference of Heroes. And today we'll speak about the importance of the correct anatomic and total mesopancreas excision to achieve higher R0 results in pancreatic cancer. There is an ongoing discussion about the correct and appropriate selection of patients. Today, on one side, many patients, due to the tumor's aggressive biology, are led to more systematic therapy. This has a consequence of over-selection of patients to receive systematic therapy. So they are precluded from stereotypical treatment. On the other side, many patients undergo difficult and surgical surgeries without clear oncological benefit. This decision is made just with having in mind just the resectability of the tumor. So many fragile patients go and be operated, and then that leads to higher morbidity levels. The first time that the term mesopancreas was used was by Ian Innes-Gogel in 2007. It was explained as a connected neurovascular seat located retroportally, posterior to the pancreatic head on the fusion fascia of trikes, extending to the level of the SMA. The mesopancreas is a retropancreatic neural plane located between the pancreatic ancient process, the superior mesenteric artery and the superior mesenteric vein. It contains nerves, fat tissue, connective tissue, blood vessels, lymph nodes, and lymph vessels. What we know about the mesopancreas from anatomical studies is that the most important components are the nerves and the lymphatics. The Japanese, in the last year, gave an explanation and description about the pancreatic cancer dissemination. They described the mesopancreas with the nerve plexuses. They found out that there are 4 nerve plexuses, PH1 and 2, that are behind the pancreatic head and the pancreatic calcinate process, the PLCE, the plexus of the celiac trunk, and the PLSMA, the plexus of the superior mesenteric artery. In this image, you see the mesopancreas in the first image, and the second image, you get an idea of what mesopancreas looks like in the CT. The concept of mesopancreas is challenged. There is not an exact anatomical area or a fascia or something that can define the boundaries of the mesopancreas. That's why many names have been given to this area. It's not easy to evaluate the infiltration of the mesopancreas through imaging. Neither CT nor MRI have been able to visualize the nerve plexuses of this area. Also, there are no distinct imaging signs to evaluate the malignant infiltration. In the second image, this image can be to patients with pancreatitis or pancreatic cancer, so we don't have very good imaging information. Recently, it has been reported that the mesopancreas plays a pivotal role in the spread of pancreatic tumor. The nerve plexus and the lymphatic pathways are implicated in the metastatic spread. Also, the mesopancreatic margins are the margins that are found positive in the most of the pancreaduodenectomies. The peridural tumor invasion was observed in up to 77% of the resection specimens from patients with pancreatic head carcinoma. The mesopancreas is considered the main site of a positive resection margin. Careful total mesopancreatic excision can provide the patient lower recurrence rates and the chance of higher survivability. To achieve this, the resection of the peripancreatic lymphatic structures along with neural plexus posterior to the pancreatic head and on the right of the superior mesenteric artery is needed. It was suggested that unblocked resection of this structure during pancreaduodenectomy would reduce local recurrence because of increasing R0 resections. Even in patients with localized tumors, primary pancreatic duct adenocarcinomas, the resection of mesopancreas was shown to provide better oncologic results. The mesopancreas is the most common area of recurrence and the positive margin. So, a limit of at least 1 millimeter is needed to achieve R0 excisions. That's the goal on this area. The high rate of non-curative resection in patients with pancreatic ductal adenocarcinoma is mainly related to close anatomical relations of tumor with the SMA and SMV, also the celiac trunk. Another issue is that is closely related to mesopancreas is the extent of the lymphadenectomy. This image, in this image in gray, we see the lymph node stations that needs to be resected during a standard Craiova procedure. Surgically, mesopancreas resection has 4 levels of dissection. Level 1 is division through the mesopancreas without the resection and on the right side of the SMV. This is not an acceptable procedure. Level 2 is mesopancreas resection and block with lymph node dissection and ligation of JV1, JA1, and IPDA. This level of dissection is accepted for pancreatic adenocarcinomas that are far from the SMA. The third level of resection dissection includes the periarterial plexus at the tumor oriented on the right side of the SMA. And there's an extended level 3 where complete circumferential removal of the periarterial nerve plexus. Back. Here you see in detail the level 1 dissection. You see in the main image that the dissection goes through the mesopancreas on the right side of the SMV. This is level 2 dissection, where the whole mesopancreas is resected on the right side, this time of the SMA. Also the JA1, JV1, and IPDA are ligated. Third level, we see in the first image that the right side of the plexus of the SMA is resected also. And here in image G, we see the extended level 3, where SMA is divested. These are some anatomical variations that we may encounter during our surgery. Here we see some operative fields of before total mesopancreas excision and after, where all the blood vessels are clear and skeletonized. Now, patients that underwent extended level 3 dissection may suffer from post-op diarrheas. This is due to the excision of the nerve plexus around the artery. In most cases, this appears to be well-controlled medication, and they can proceed and complete adjuvant therapy. The triangle operation. This is a concept that has been introduced from Heidelberg. Actually, it aims to complete mesopancreas resection. Another problem, another issue that we may encounter is what we'll do with the 16A2 and 16B1 lymph nodes. The resection of these nodes is not something that is normally done, but also the infiltration of these nodes, according to TNM, is metastatic disease. But studies have shown that resecting them with a block with mesopancreas confers to more R0 specimens. Our first approach, instead of standard dissection, seems to facilitate mesopancreas resection. Cut and brush maneuver also facilitates artery first approach complete excision of the pancreas, and also we can reveal the IPPA and JA1 easier that way. Now, minimally invasive approaches provide the visualization procedure and dexterity. Robotic platforms facilitate more precise dissection around critical structures such as the SMA, the celiac plexus and trunk, the portal vein. Thereby, you can reduce the risk using these techniques. Here are some images through robotic from robotic procedures in this area. Thank you very much for your attention.
Thank you very much, George. I believe the next speaker will give us a new perspective in tumor margins, especially in demanding and difficult operations. So, last but not least, George Makopoulos, another George. As you see, we have three of them. He is our scientist, he's a biologist, well-respected one, and our new soon-to-be assistant professor of physiology. He will explain us the secrets of flow cytometry. And we are proud that the Ivanka protocol, which is well established in literature, is used already to rapidly recognize and characterize the surgical margins during the operating theater, during our difficult operations. So, George, tell us the secrets of flow cytometry. Thank you.
Thank you for the kind introduction, Professor. So, we will talk about intraoperative flow cytometry in surgical oncology. So, let's start with cancer. Cancer is a group of diseases that includes malignant neoplastic cells, which exhibit abnormal growth leading to tumor formation and the ability to infiltrate adjacent tissues and metastasize to other parts of the body. Cancer is the second cause of human mortality. Among the hallmarks of cancer, some of them lead to advanced replicative potential, like sustained proliferative signaling, evading growth suppression, and enabling replicative immortality, as well as genome instability and mutation may lead to unemployment. As you all know, surgical dissection of a tumor is a potential cure and depends on tumor margins. So the golden rule is to remove the tumor and conserve the healthy tissue. And also, operation time is a limiting factor. In total, we have a need of specific and fast methods to delineate cancer cells and tumor margins intraoperatively. So, let's talk about what intraoperative flow cytometry is and what is its principle. No, you have a marker to. Yes, the button. Okay. The B or the play button? Yeah. The B? Yeah, okay. Okay, found it. So, starting from cancer, okay, we take a tissue specimen from cancer, we homogenize it in order to have single cells, and by using flow cytometry, we can analyze DNA content and more recently tumor markers, and we can predict the tumor grade and the margin status. Among the analysis of intraoperative flow cytometry is that of DNA quantity. So, based on the cell cycle of tumor cells, we can predict two malignancy indicators. First is the tumor index, which exhibits the replicative potential of the tumor, and also the DNA index, which is the ratio of DNA relative to diploid cells, and can reveal the existence of tumoral diploid. How intraoperative flow cytometry is applied? Let's see an example. In our example, we have aneuploid tumors. These are aneuploid cells, and this is the diploid DNA markers. So, we can analyze the tumor and find the diploidy, and as we go to the tumor margins, we see more diploid cells along with the aneuploid ones. And as we move towards the margins of the tumor, a negative margin is one with only diploid cells. So we can have an accurate tumor characterization and resection or tumor-free margins. Which is the advantages of intraoperative flow cytometry. First is the speed of analysis. Between 3 to 7 minutes, we can analyze a tissue specimen for existence of cancer cells. Second is the high sensitivity and specificity of the methodology, with diagnostic accuracy more than 9% in most cases. And quantitative diagnosis at the cellular level, which help us discriminate between cancers and normal cells. Next. Okay. Some applications of intraoperative flow cytometry. Intraoperative flow cytometry has been applied in brain malignancies, also in breast cancer, liver and pancreatic cancer, colorectal cancer, as well as many other malignancies. Let's see some significant examples. First, we will talk about DNA analysis in gliomas, a study that we have the fortune to have the honor of the Academy of Athens prize. In 88 cases of gliomas, we managed to discriminate between low and high-grade gliomas with an accuracy of more than 80%. Next, touching print intraoperative flow cytometry. In this case, a resected liver can be imprinted, and the cells of this cell, the whole cell resected area, can be analyzed for the presence of cancer cells. This protocol of hybrid flow cytometry has been also applied for intraoperative analysis in pancreatic cancer with high accuracy. As regards intraoperative flow cytometry in colorectal cancer setting, in a total time between 7 to 10 minutes from sample collection to DNA analysis, we can predict the diploid status, tumor index, so we can identify cancer cells and evaluate margin status. In a study of 106 patients, the accuracy of our methodology is more than 90%, 91.1%, with 82.2% sensitivity and almost total 99.96% specificity. Our next question is, could flow cytometry also provide prognostic markers in colorectal cancer? The answer is yes. We followed these patients for a period of at least 3 years. We found that high tumor index, based on intraoperative flow cytometry, the patients with high tumor index more than 20% have significantly less survival than the group of low tumor index. And also, intraoperative flow cytometry markers can predict TRG status. In a more recent study with the Department of Plastic Surgery and Professor Seredis, we have applied intraoperative flow cytometry for diagnosis and validations in non-melanomas kidney cancer. In a prospective clinical feasibility study of 30 patients, our accuracy is more than 90%, with a high sensitivity of 95.2% and 87% specificity. More recently also, we have applied intraoperative flow cytometry beyond the cell cycle, and using tumor markers, we found that cytokeratin expression is able to characterize a cancer of a non-primary intraoperative. We have also applied intraoperative flow cytometry in breast conservative surgery, and in a study with 99 patients, the accuracy of our protocol was more than 9%, with a high sensitivity and specificity. And due to that, our protocol has been proposed as a next generation margin evaluation technique in breast conservative surgery. So, in conclusion, intraoperative flow cytometry can accurately characterize cancer biology and tumor margins, and specific individualized protocols can offer increased accuracy based on the type of surgery. Recent data support that the usefulness of IFC in surgical oncology as potential tools that supports accurate diagnosis, prognosis, clinical management, and also individualized therapy. If you want to see more about intraoperative flow cytometry, I suggest to read this book, Intraoperative Flow Cytometry, having the honor to be written by staff in University Hospital of Ioannina, University of Ioannina. And closing this, I would like to thank all people in the Department of Surgery at University Hospital of Ioannina. Thank you, Professor Lachos, for the support. I would also like to thank people at the Department of Pathology at the University Hospital of Ioannina. Having the golden standard is always the base in order to build all this. And also the FC team at the University Hospital of Ioannina, Savas Dimitriadis, Nikothea Dova, and a huge thanks to Professor Bartholomatos, who is also my mentor in cytometry and a pioneer in intraoperative flow cytometry. I would also like to press this, to have his salute in your language.
Dragi colegi, μαζί foarte onorați și bucuroși pentru că am ocazia să vă adresez salutări calde și să vă urez succes la congresul dumneavoastră. Sunt convins că o să fie plin de discuții creative pentru cytometrie intraoperativă. Sper data viitoare să ne întâlnim și să discutăm în limba romană, face to face. Cu respect, George Bartholomatos.
Professor Bartholomatos has studied in Bucharest biochemistry, so he's a fluent Romanian speaker. Thank you for the invitation in your lecture.
Thank you very much, George. And I would like to make a comment because I see a lot of endocrine surgeons here that the last, let's say, application of flow cytometry is to define between the Bethesda 3 and Bethesda 4 FNA aspirations, if we can detect with flow cytometry the cancer cells, which will be something new and we can use it in the operating theater. Thank you. Are there any questions? Thank you very much all.
Ευχαριστούμε πολύ, δεν υπάρχουν. έχουμε και μια κοπέλα.
Ναι. Βαρθολομάτης που είσαι φοβερός βιολόγος, είναι εδώ, είναι και φοβερός χαράς, γι' αυτό δεν ήρθε. Θα έρθει στη διαφανονιά αυτόν τον μυστικό του.
Θα σας ευχαριστήσω θερμά.